Hi, Scott. How are you today?
Hey, Mark, doing great, and really excited about today's topic and guests.
It is a big one, and I think for us it's very exciting. It's like the show was picked up because listeners are sending us requests for topics they'd like to hear, and so today's is tackling copay accumulators and maximizers. It's exciting to know that we're getting some feedback from our listeners, so I'd encourage others to, whoever's listening to this, let us know what you'd like to hear going forward.
Yeah. Well, and I'm not surprised that there's interest in this topic, Mark. As you know, it's one that impacts all the stakeholders very substantially. But before we get going, would it be okay this week if I get to share our disclaimer at the beginning?
Absolutely.
All right. Well, of course, as always, the views and opinions expressed on this podcast are those of the co-hosts and the guests, and do not necessarily reflect those of any sponsors or their affiliates. Thanks, Mark.
Mm-hmm. The attorneys would be so proud.
Yes, I've been practicing.
So today we have two great guests to cover this topic. The first is Lauren Crawford-Shaver, who is the Senior Managing Director and Head of Healthcare and Life Sciences for FTI Consulting. Full disclosure, we don't have a financial relationship or anything, but I do know her CEO very well, who I've known for a couple of decades. And then we're also thrilled to have Carl Schmid, Executive Director for HIV and Hepatitis Policy Institute. Carl is well known in the DC community as well for his efforts for patient advocates and policy. So two great experts, and we're thrilled to welcome both Lauren and Carl to the show.
Thanks for having us.
Great to be here.
Good. Well, it's nice to meet both of you and welcome. We've been starting all of our interviews with a chance for our guests to briefly tell us about their backgrounds and their professional journeys to their current roles. Lauren, could you kick us off with that?
I would absolutely love to. And thanks again for having us today. I obviously run our healthcare and life sciences work here at FTI Consulting, looking at the policy, the business, the patient, the stakeholder impacts on all things healthcare, both here and thinking about it globally. Prior, my previous roles, I built a public affairs practice at a firm here in Washington, D.C. I've worked for several Democratic presidential candidates, and I have also worked at the U.S. Department of Health and Human Services under President Obama. So plenty of experience in healthcare, but you'd be shocked, and I'm glad we're having this topic in this discussion today. Everyone's focused on costs, always will be, always continue to be. So thanks for convening us today.
Great. Well, welcome. And Carl, could you tell us a bit about your background?
Sure. So I've been working at the national level on HIV/AIDS policy and advocacy for around 25 years now. And I've really been focusing a lot on prescription drug access because you could understand how important it is to people living with HIV, and now for people at risk of HIV, we have drugs that prevent HIV. And for hepatitis, I myself have hepatitis B, and I'm on a drug every single day to keep me healthy. And now we have cures for hepatitis C. But people are having problems accessing them. And so I worked in the HIV community, the hepatitis community, but a lot of different other patient groups as well, because we all share a lot of the same problems about accessing and affording prescription drugs. I've co-chaired the President's Advisory Council on HIV/AIDS, still a member of that, and I'm also a consumer representative to the National Association of Insurance Commissioners. And so this topic that we're talking about today, I've been really involved in for the last 5 years. And, patients depend on copay assistance, and that's how they afford their drugs. So look forward to the conversation today.
Yeah, great. Well, welcome to you as well.
Yeah, and I'll sort of kick off some of the content because we, this is a complex topic, right? Copay accumulators, copay maximizers. So I'm going to start with Lauren, if I could. You're the consultant, so you're paid to, not paid by us, but generally, clients will hire you to help simplify some of these complex topics. So can you help us understand sort of what are copay accumulators and copay maximizers, and maybe the difference between the two of them?
Absolutely. I'll go ahead and lay this out as simply as I can, with fair warning, it's not as simple as one may think. And Carl, please always feel free to chime in if you have any additional thoughts as well. So let's step back for a minute and just talk about copays. or co-payments, as they are formally called. These are, as they're simply defined, how much a patient pays for medical expenses. And typically, a patient pays 100% of costs out of their own pocket until they hit their own deductible, and then they have a copay. I feel like everyone who has insurance knows you go to your doctor's office, you have a $20 copay. You pay for a prescription, you have a $5 copay. And that's a way, a long way of making sure payers have expanded their use, have shifted from some of these brand drugs to generic drugs, which is obviously has a cost implication to them. So let's start with that as our basis. About 5-ish years ago, maybe 5+ years ago, around that time, this concept of copay accumulators and started kind of coming out, and that was a reaction to a copay assistance program. So a copay assistance program are one where pharmaceutical manufacturers who are creating some of these new and innovative drugs that typically have a higher cost are looking for ways to help patients gain access to that medicine. They're typically patients who are underinsured, so don't have a plan that fully covers everything for them, but helps to give them some relief in getting to their program itself. I should also clarify, this is different than need-based patient assistance programs. So these are separate, and I think sometimes these get thrown together and they're different. The copay assistance were really focused on the underinsured to make sure that they had access to the drugs that they needed. So let's turn to what these actually are and what a copay accumulator is. About 5-ish years ago, many insurers would say, this is where the insurers and the manufacturers diverge on the story of these programs itself. About 5 years ago, insurers would say that these copay coupons at their core are really like a marketing tool. They'd be something to get patients onto a specific medication that costs additional money that then would get them through their insurance process faster, so the insurer would have to be paying more. So let's take this in terms of dollars and cents, and I'm going to use round numbers, which are totally made up, but will help us all do math better and more efficiently. So in a copay assistance program, if a patient needs access to a drug, well, let's say is $1,000 a year, and they have a copay that will, my numbers are probably not going to work that well, $1,000 a year, but they have a copay that gets them that's going to help be like something like $1,000 a month, something that's like massive. What that company is, what the copay assistance program will do will help pay that money to hit that medium, that deductible that patient has to pay for, and then their drugs will be paid for the rest of the year because they have met that deductible. When you talk about an accumulator program, what the accumulator program would say, because that coupon is being paid for by the manufacturer and not the individual, it doesn't count towards that program. And then that patient will still have to pay that out of cost. And this is where, again, the manufacturers and the insurers differ on the value of what they are doing. The manufacturer will say, I'm helping the patient get access to the medication that they need that ultimately helps them. And the insurer was saying, well, you're just passing money through and you're shifting money within the process. So this is kind of where it goes down to who pays for what. And it's a little bit of rearranging deck chairs on what's really happening and who's paying for what. But that's really the nuts and bolts of this. Who's ultimately paying to hit that deductible so that patient has access to their medication.
So I may want to add a little more. I think, Lauren, you're being too nice. And, so the way a copay accumulator works is first the copay assistance is being paid by the drug manufacturer. And then once it runs out, they then go to the patient and ask them to pay if you want to continue to take your drug. And so in my view, they're double billing. And I think they're really ripping off, the system.
And how about the difference between the accumulators and maximizers? Can you elucidate that?
Absolutely. So the maximizers are an additional newer program that you're seeing more often through insurers, where they're going to take a look at the individual's cost sharing amounts in their insurance, and they're going to say, oh, this manufacturer is going to pay $10,000 throughout the year, and rather than hit that deductible, hit that payment at the very beginning of the year, they're going to split it up and divide it by 12 months and say, this is what we know you're going to hit each month, so we'll divide it up that way. So you never really hit that maximum number, and the insurance isn't paying for it, anything at the end. The insurers are taking the maximum amount from the manufacturer and dividing it by 12 to hit that plan year.
Mm-hmm. I've heard it sometimes
Go ahead.
described, Carl, as a little more patient-friendly, the maximizer, because the patient doesn't really hit that. But it still sounds like it has that double dipping thing that you were talking about.
I'm going to say more than double dipping. And because what they are able to do is to collect more money than what they're legally entitled to. We'll say the out-of-pocket, maximum is like $9,000, give or take a couple $100. But if the copay assistance is like let's say $12,000, and you divide it by 12, that's $1,000 a month, and that's higher than the maximum out of pocket. And so the patient is not hurt, but that's only if you look at the spend on drug. Remember, cancer patients, HIV patients, they have a lot of other medical costs as well. And once you satisfy your deductible, you don't have to pay for that. The insurance does for these other things. So if you're just looking at the drug spend, it doesn't hurt the patient. But we have to remember people and they're on other drugs. As well. So, it's just harder and harder to fill in your your deductible and meet your out-of-pocket costs.
Yep, interesting.
Well, could I just sort of follow that up, Carl? From your perspective, again, you've been a patient advocate for some time. Help us understand, bring this down to a day-to-day base, day-to-day. What's it like for a patient to be able to, when they're facing one of these programs, either the accumulator or the maximizer?
Yeah. So most of the times people don't even know that they're being subject to this, because the PBMs or the insurance companies are not putting this in their documents that people, when they select their plans, read. And it's not on the summary of benefits and coverage page. That's like that 8-page document that shows how much you paid for each drug and things like that. But it's buried in plan documents, like on page 150, and who knows? You have to look for it. And if you don't even know about it, why would you even be looking for it? So people don't know about it, and they pick up their drugs like they think it should be normal times, and because they have the copay assistance from the drug manufacturer, they pick up their drug. Well, then they find out a couple months later, they go and pick up their drug, and they're stuck with $1,000 or $2,000 bill, and they say why. And they don't know that that copay assistance was not counting for their and towards their maximum out-of-pocket cost. Mm-hmm. So what happens then? They probably don't pick up their drug. People don't have that type of money. It's an unplanned expense. People these days, especially in this high time of inflation, and high cost of living, people just don't have that type of money. So they don't pick up their drug is the most likely outcome, unfortunately.
And Carl, to piggyback off that, I know you and I have done some work before where we've seen most Americans have somewhere in their savings account between $600 to $1,200. And so if you are planning on one of these programs to get to a deductible and then you're suddenly out $1,000, that's a significant amount of money that you have that's your backstop that you're suddenly out. So you're definitely not going to be able to go pick up the next round of medication. And that obviously has huge potential costs to people who need those medications.
Mm-hmm. Interesting. So Lauren, as in your work as a consultant, I know you work both with the plans and plan sponsors on the one hand, but also manufacturers as well. Maybe, share us, to start, your perspective, from the plan's perspective. How do they think about these things, and when do they choose to offer them? How do they recommend, the accumulator versus the maximizer, things like that?
Well, first off, I'm not speaking directly for a plan, but in terms
course.
of thinking about them, everyone, everyone in broader healthcare is looking to find ways to drive down costs. And costs can be to the broader healthcare system, to the federal government, and then to the individual out-of-pocket component of this, right? And I don't know exactly how everyone's focused on this, but I do firmly believe everyone in healthcare is trying to make the best decision for the patient themselves. And so if a plan or a PBM is looking to do something, they're ultimately trying to make sure they are getting the most cost-effective and effective treatment to the patient themselves, just like the drug manufacturer is doing as well. But where I see a lot of, to Carl's point, of challenges here is that the information is buried deep inside of a plan. So the facts are very, very hard for an individual to understand and see what they're ultimately signing up for. And quite honestly, if you're not in healthcare, the concept of deductibles and copays and accumulators and maximizers and adjustments and all of these pieces is quite overwhelming. So the challenge of navigating the system is very real for patients. And I think that's actually been a huge concern in kind of the massive growth in accumulators, and I would say even the faster, more rapid growth in maximizers we've seen in the system. It's really a how are we moving payment and how are we moving money around, and who's ultimately keeping it rather than in the end. And that's what we're seeing a lot of happening right now.
But speaking of keeping it, I mean, is some of this being driven also by the consultants? Because I know those firms are out there making a percentage of the copay dollars that come in through these programs.
Yeah,
and so they're pushing it aggressively.
Yeah, I mean, I think like I'm gonna not defend my industry a little bit, but there are people looking at ways in the healthcare system to create those types of efficiencies, and some of them are different efficiencies than others. And so yes, there are. I have heard of. I do not do this. My team does not do this, but there are some consultants that go out there and assess certain plan designs and find ways to make changes that do have incentives for them to point that out. Yes.
If I could though, Scott, if I could go back on one thing,
Sure.
which is back to Carl, because Lauren talks about like reducing the cost of healthcare, but what it sounds like is it's making more money for the payers and shifting those costs to the patient. That sounds like what this is. So, you mentioned that they didn't fill the drug. I mean, what is the implications of this for patients? And are you starting to see, even, patients getting sick again?
Yeah. And one thing that we also have to remember, this is all after people pay their premiums, and those aren't cheap. And those are, could be, if you're a family, this starts adding up, especially if you have to pay it on your own and if you don't have support from your employer. So this is all after, the premiums that people expect. Oh, I have health insurance, and that's great. But then they, can't afford to use their health insurance. And, they have to, I have to give credit. There are maximum out-of-pocket costs now for individuals around $9,000. But for a family that's two people or more, it's $18,000. That's still a lot of money. So with high deductibles, and, people have to make their choices too, that, if they can't afford a high premium, then they may be stuck with high deductibles, and that could be $7,000-8,000. And people just don't have that type of money. So yeah, people go without their drugs, and it's very sad to read the stories of people, because they have to, you have to have a shelter over your head, you have to have food to live, and that's getting more expensive, and then and transportation, and then you have to afford a medication. And people, when they are stuck with these copay accumulators, that they didn't anticipate, and that makes it even harder because they couldn't even budget for that because they didn't even know about it. People go without their medications and they get sick. And there's been some studies, that shows that people with copay accumulators are delaying their treatment. They don't have, their health outcomes are not as good. And and we've seen some media stories too of very sad stories of people not taking their medications for them or for their kids.
And that's why, actually, I'll jump in and say, that's why you're seeing action, not just in the media reporting this at this point. You see state legislatures taking action. And you see a lot of people stepping in saying, the implementation of these accumulators programs has a negative impact on people. And I believe that we're at 17 states in Puerto Rico now that have outlawed copay accumulators within their states. And there's obviously a lot of momentum behind that, because there is, now that we've done this for 5 years, we are seeing the impact of it.
Yep.
Right. But it's great, and I'm working on a lot of states to grow that number this year, but it's not the solution that we need. And because they only represent, well, it's taken a lot of time and work to get those, state by state. And we're up against a lot of opposition and a lot of things that aren't always true are said, and I'll be nice. And and it only goes to those plans that are state regulated, and most people get their insurance, they're in larger employers. So we do need a national solution to get at accumulators. And Mark and Scott, you want me to? I could talk about some of those things that we're working on.
Sure, that'd be great, Carl. Thanks.
Absolutely.
Yeah.
Go for it.
Yes. So, my organization has filed litigation actually against the Department of HHS for promulgating a rule. It's called the Notice of Benefit and Payment Parameters Rule, and that's the rule that governs all plans every single year. And in 2020, for the 2021 year, they said that that copay assistance does not have to count. And since then, we've seen the growth of these programs. And so we feel that it is a violation of the Affordable Care Act for a number of reasons. One, as I said earlier, that these insurers are collecting more money than they're entitled to. There is a maximum amount per year that they can receive. And they are, since they're double dipping, they're getting more money. Secondly, the regulations that implement the Affordable Care Act says that cost sharing is on our behalf of the beneficiary. And this is on behalf of the beneficiary, these payments. Also, this is an Administrative Procedures Act that was filed last August, August 2022, in the U.S. District Court in D.C., and it is an Administrative Procedures Act for a number of reasons. One, that we say it violates the current law, that's the ACA, but also the way that the rule was promulgated. And it says that it really leaves it up to the PBMs and the insurers to decide the definition of cost sharing. And that's not right. People, you need certainty. And it either means, what does cost sharing mean? We shouldn't leave it up to an outside entity to decide. So those are some of the reasons that we filed litigation. I hope it will end by this summer. On May 1st, we filed our reply to the government's brief, which I don't think was very strong. And so we may go to oral arguments during the early part of the summer or not. But I hope that we will be successful in saying if we are successful, then copay assistance would have to count. There's also, we're looking at legislation at national level. There's been bills introduced in both the House and the Senate to say that copay assistance has to count. And of course, we could always get the administration to issue regulation, but we have not been successful in that. And that's why we've had to turn to litigation.
That's interesting, Carl. And so, if you had to handicap things and think about, how this might turn out, what do you think about the chances for your lawsuit or the chances for federal legislation or regulatory action?
Well, I think well, we failed so far with the regulatory action.
Yep.
It's really been disappointing. We tried with the Trump administration, then we tried a couple of years now with the Biden administration. And as I said, I'm disappointed because they want to lower the cost of, drugs for people. And this is a perfect way. And this is actually increasing patient costs for prescription drugs. I think it's going to be difficult to get Congress to agree on this. They are considering PBM reform, and so there's a possibility of getting it in there, but I think that's an uphill battle as well. We're up against some very powerful forces. So I'm not a lawyer, but I don't think that the government has made their case that they didn't take on the whole double dipping issue at all, and they just said they used one paragraph, and so I think that our case is strong, and I hope people are following it. And the government has to file their response the end of May, and then it's up to the judge. We may have oral argument, or he'll decide.
So I think one thing Carl's pointed to is really important here. I think there's 4 major lanes that we are talking about: copay accumulators, maximizers, and what this really means. And again, this is ballooned in the last 5 years from a copay assistance program so people could get the new innovative drugs that had a little bit higher price tag, to suddenly everyone adjusting how your benefits package was to focus on those cost containments and moving around. So one is the legal route that Carl is spearheading and leading and making sure that case is present. 2 is any federal action that can happen, and obviously the bipartisan work and approach to figuring out protecting costs is critically important, but nothing's happened there. You're seeing action at the states, as Carl alluded to. It takes a lot of time. State legislatures are typically in session for 1 to 4 months, and some of them don't even meet every year. So going from 17 to 50 is going to take quite some time, and obviously patients don't have time to think about that. And I think the 4th lane is explaining this and working with the media and reporters that this is not just, this is huge implication for cystic fibrosis drugs and treatments, but also has a huge complication for those who have ulcerative colitis or Crohn's and are seeking their regular treatment based on what they need day in and day out. And this really impacts more people than I think we assume, because the more it gets into everyone's day-to-day plan design, the more it impacts their out-of-pocket. So across all 4 of those lanes, I think I should say that the most important one is the storytelling aspect of how this ultimately impacts people. Because we're here having a discussion on policy where we're moving dollars from a manufacturer into an insurer versus out of a patient to an insurer to a manufacturer. But patients need the treatments that ultimately help them live their lives day in and day out. And we need to get back to that storytelling. That's ultimately the decision here. And over the last 5 years, we've put a whole bunch of other people or systems or structures in between what the physician tells the patient they need.
Lauren, thanks for that. And, in the meantime, we read and hear and understand that the use of the programs is actually growing quite rapidly. Can you estimate what their penetration is now and where it may be headed?
Well, Adam Fine has a great blog on this. I'll point it out. But, he said something I think it's something 76% of plans have accumulators at this point. I think we're just under 60% on maximizers. Which is huge, considering this is, again, 5 years. If we're talking about something
and I've read
20, it's different, but 5 years.
Right. And the corollary to that, I've read from the manufacturer perspective that their spending on copay assistance has also likewise ballooned. Any comments on that? How are the manufacturers reacting to all this?
Manufacturers are really focusing on making sure that drugs are in the patients and in the hands of patients that need them most. And they're really zeroing down on that. Much like I'm assuming that the payers are doing something similar, but that's ultimately where everyone is what do what do the patients need.
Yeah, so could I comment on that? So I don't have the numbers, but it's billions and billions of dollars, right? And 17, 18 billion dollars, I think, is the recent estimate of how much manufacturers spend on copay assistance. And maybe they, one of the reasons why we haven't been so successful in the media and with regulators is I don't think they understand, because that the magnitude of that number. Prime manufacturers don't go around talking about it, but I talk about it, and I think it's important to show that if we didn't have copay assistance, that's how much money patients would have to come up with, and that's a lot of money. And we've seen reports that the amount is growing because of these copay accumulator programs, because of these maximizer programs. And so I think that it gives further reason for our litigation and against the argument that they're not that they are double dipping, and because it is costing manufacturers and patients more money. One of the things, and this is perhaps another show, but we wouldn't be here talking about copay assistance and if we had better insurance benefit design. And, because as I said earlier, this is after premiums. We have high deductibles. We have high coinsurance. When's the last time you went to an emergency room and paid 50% coinsurance? But they seem to do that for prescription drugs. And something is wrong with our insurance benefit design. And that's, and it's nice to go to the media. I go to the media to get my points across, but we need legislators to step in. And our regulators to put, I've been a proponent of standardized plans, capping copays, and that's the only way people are going to be able to afford their prescription drugs.
And I think, if I could, I just want to go back to Lauren's earlier point that this copays were designed to, to encourage people to move off of a brand to a generic. Now copays are used for single source drugs. There's no alternative. You got diagnosed with cancer, whatever, you're facing something tragic. You have CF, or as you said, Crohn's, or HIV, or hepatitis. I mean, these are things people don't want to have. And so now to be faced with this, to put the full cost of these sort of copays and increase the copays and even have a copay is outrageous. So I think from our perspective, we've heard this consistently through all of our podcasts, that the benefit design itself has to change. Lauren, do you have a perspective on could the benefit design change as we look ahead?
I sure do. I think overall we have to look at plan design and make sure it is designed with the patient at the center. And ultimately think about what it is that we're serving that creates, I'm going to use all the buzzwords here, value, that creates rooted in research care, and also thinks about preventative medicines. And this is really what you're seeing a lot coming out of the CMS right now is value-based care, right? Is we have to move from a plan design world that focuses on people getting the best preventative treatment and care proactively, and then obviously a payment model that incentivizes people to do that, not just treat you when you're sick. Now, obviously, when we're not talking about plan design for these medications, we want the best new innovative treatments that are coming to market because they work and they're making people healthier, and they're also saving us money longer term because we are keeping people healthier and longer. And so we have to then fundamentally change what insurance was, which was paying for you when you got sick. And that's the way I think we need to step back and think about plan design. But that's not just like a tweak on the corners. That's like a full overhaul of how we're approaching patient-centered care.
Well, in the meantime, we read that manufacturers are starting to, respond on their own. As Carl pointed out, it's billions of dollars a year, and it's rapidly growing, as you cited, Lauren. And I understand, that several manufacturers have begun to contemplate putting limits in place for their copay assistance programs. Are you familiar with those reports, and how might that impact the patients as well.
Carl, do you want to jump in or do you want me to take that one?
Why don't you start?
All right. Thanks, sir. So I think, yes, some manufacturers are stepping in and thinking about how they are working with their patients. I think most notably, Vertex has made some changes. I think that's the one folks can see in the news regularly, specific to some of their CF medication. They're putting a cap on what they're going to put out each year. Now, that does impact the patients and the care that they're able to seek and what they're able to get through their insurance and their coverage. That might mean that they have to shift to a different medication. That might mean they're paying some more out of pocket. That might mean they're going to look for a different plan. But it's an attempt by the manufacturers to say, wait a minute, we're just giving money away right now to a PBM because of the way they've structured this plan. That's not what this program was designed for, and we're going to start taking that back. They've been quite aggressive. That goes into effect this year. But I know manufacturers are taking a look at their programs to make sure that they ultimately have the patient.
And I've also read about the, sort of the emerging edge of this, that some plans now are going a step further in declaring certain medications non-essential and therefore not covering them at all, and then referring patients to the manufacturer's free goods program. Is that right?
I could take that one. And this is like from the playbook, you just can't make it up. And it is unbelievable. We're mostly seeing this in the self-funded market. They're taking advantage of perhaps a loophole in the Affordable Care Act and the definition of essential health benefits. And so what they're doing, these players that are getting a cut of the money, as you talked about earlier, looking at ways to make money, and they're going to these employers. We have I don't need to worry about mentioning names or not, but it was a Cigna plan, and they went to a employer, and they work with a group called Save on SP, and they have a long list of drugs, many of them in HIV and hepatitis, actually the biggest selling HIV drug right now, and many cancer, arthritis drugs, rheumatoid arthritis drugs are on this list. And they said, well, if you want to stay on okay, remember these people have insurance, but
Pay their premiums.
Or their employer does. And you get a letter and say, if you want to continue on this drug, you have to sign up for this other program, which Save on SP is not insurance. So you don't have any of the protections. And what they do is, they'll say you don't have to pay anything. It's zero. And if you don't, now other plans say you will have to pay full price of the drug. This Save on SP, this one says 30% co-insurance you'll have to pay if you want to keep it through your insurance. And if you, but Save on SP then says we will seek manufacturer copay assistance. So here, on one hand, they're fighting copay assistance. On another, they're milking it. Now, there's some other companies out there, too, that say we will put you on free drug programs. Now, remember, those free manufacturer drug programs are for people who are uninsured. These people do have insurance, but they are putting them in a program that makes them uninsured. They also, another one says we will seek imported drugs. And the FDA has recently sent a warning letter to that entity for doing that. So this needs to be stopped. It's just that it's taking advantage of a loophole. Hopefully Congress could set in. We need media attention on it, but it is just bizarre what people are doing.
Could I, if I could, because this is, my wife says always, this is why I don't have any hair, Scott. Because whenever I get stressed, it's like, I can't believe this, right? Like, this is just so upsetting. Carl used to have hair as well, but but if I could, these are just terrible impact on patients. And so
it's very risky.
Yeah. And it's leading to obviously just, the whole point of having insurance, the whole point of Obamacare, the whole point of why we're doing what I started my career when we had, you know, pre-existing conditions and people getting, maximum, you know, benefits, and then they're kicked off their plans. I mean, we got rid of that. We don't want to go back to that. But I guess my question is, with these things coming from the payers, right? These are like, boom, these are body blows from the payers to both the manufacturers and to the patients. What can be done? Like, what are there solutions? We have a lot of listeners, a lot of different stakeholders from across, different spectrums. Help us. Are there other things that can be done? Any new technology? Any sort of better way?
Well, I'm going to say this, and obviously Carl's going to lead with the legal front on the actions being taken here to stop this. But I wouldn't call them body blows. I would call this experimental, and they're tests in a system that ultimately test patients, and that's completely unacceptable here. This is an attempt to figure out who can hold more market share of the payment as they think about a person's health needs. Mm-hmm. And that's what's going on here, is who can hold most of that. And at a time when the pharmaceutical industry is booming, coming out of COVID, coming out of some new and innovative therapies and treatments that are, again, helping people live longer, better lives. And we're looking at plan design that ultimately is asking these questions and testing this out without patients truly understanding what's behind the wall. And so we need to start getting patients informed and start calling out what this is and why they signed up for one thing, but they're getting something else because it was on page 18 of their paperwork they signed. And we've got to put patients at the front of this, because they're the ones being duped in this moment.
Mm-hmm.
Carl, thoughts?
Yeah, I don't know what to add. I mean, I do think that patients need to speak up more, but we're being worn out, I think, and maybe that's the whole goal. Is remember, to get to your drug, you still have to go through a prior authorization process, step therapy, all these other barriers. And I started earlier. I'm a consumer representative to the National Association of Insurance Commissioners. There's, we're like 20 of us, and you go into their meetings and there's like 3,000 people there, and they're all from, mostly from the insurance companies, and we're up against, a big, and the drug manufacturers don't have a very good reputation, these days, which makes it harder. And, so I think, and that's been one of the reasons why the Copay accumulator issue has been, yes, it's complicated, but two, it's drug manufacturer copay assistance. Oh, it must be bad, and of course it's not. But the other side does make it out to be bad. And so, I do think it's an education to lawmakers, to the media, to improving the image of the pharmaceutical companies, and also call out what the PBMs and insurers are doing a little more. And we do have, and who knows what they're going to think of next, because it's a body blow or whatever, but they're going to keep on punching, unfortunately.
And if I could, let's not forget that the payers are also receiving the rebates.
Correct.
Yeah.
Right, and a whole host of fees, and a whole host of other things. We cover this on episode 6 with Mesfin Tageno, and so there's a lot that manufacturers are already stepping up and paying.
Well, we always close here by asking our guests for their prescription for better access. So there's a lot of moving parts here. Carl, maybe I'll start with you. If you had a magic wand, what would you like to see happen to improve patient access?
I think we need limits on copays. We need to make sure that people don't have to go through a huge deductible before they kick in. And so that's why I've been an advocate of standardized plans.
Yeah.
And, for prescription drugs.
Yep, good. And what would you add, Lauren?
Well, first off, I want to echo everything Carl has said, because we do need standardized plans. I also, with standardized plans, I want more education about the patient being at the center of their care. Because once they truly understand their plan, their care, and have that kind of that broader relationship, they're going to be taking better care of themselves. They're going to be more focused on getting all the treatments they've been prescribed. They're going to understand any cost and what it means for them. And once we have people focus on that, we're going to have better uses of our systems, period. But right now, there's just too many gray area walls being thrown up because people want to assume as much cash as they can on certain sides, and that ultimately impacts patients. So I really think making sure that education and the patient understanding increases along with more transparent plans.
Yep.
Well,
Thank you.
I think they're both of you have been fantastic. So love your prescriptions for better access and your thoughts. And so let me thank you both for taking the time to get us up to speed on Copay accumulators and maximizers. And sounds like, Scott, we need to do another episode on I don't even know what they're called, these exclusion programs or these lasered out drug programs. I think that's gonna have to be a whole episode that we tackle. But thank you both to Lauren and Carl for joining us today.
Thank you so much for having us.
Thank you.
So Scott, I don't know, I can go first if you want on some of the key
Sure.
takeaways from today.
Yeah. What were some key takeaways, Mark?
Well, I'm going to start from the beginning, which is that copays have gone off the rails, right? That they, what they were intended use and what they're being used for now is just night and day. And I think that's, I know payers are using the same, it incents people, but then they have a copay for life-saving medicine, So it's just, to me, it's gone off the rails. Second, I did not know, and I appreciate Carl bringing this up, and Lauren mentioned as well, that payers are not upfront about these accumulators and maximizer programs, and that you think you have health insurance, you're paying for health insurance, you've had it probably for years, and then a new program gets introduced that you're not even aware of, and next thing you know, your child or your spouse or your parent or whatever you're dealing with is struggling. I love that Carl's been proactive and in filing the lawsuit, and I really appreciate Lauren's 4 lanes. I'm gonna steal that from Lauren and use that because I think it makes a lot of sense in terms of what we have going on. I'm encouraged by the bills that are in front of Congress. Having been in Washington for a long time. I'm not as optimistic. I think as Carl said, it's a little disappointing. And then it all comes down to better benefit design. It's like maybe we should just blow up insurance as we know it today for drug coverage and start over and think about something better. Maybe that's ultimately the best prescription for better access. So anyways, those are some of the key points. You?
Yeah. All good
else?
points, Mark. Yeah. Well, for me, from all the guests we've been speaking with, we've been learning about how much stress the system is under and the dysfunction of the system that we've created and the reactions that are occurring, from all that stress. And this is sort of a pinnacle example of that in some respects. I mean, it is so complicated, so difficult to understand and so dysfunctional, as Carl and Lauren both pointed out as well. I think it's a great example of what Jamie Robinson, called the war of all against all, just sort of the tactical back and forth that's going on amongst the parties. As Lauren described it, as sort of kind of, trying to decide who's going to pay for what in the overall expense of things. The unfortunate part is that it creates a ton of friction. It tires patients and doctors out. It keeps many of them from getting even medicines that they really need. It's expensive. The navigation of all of this is extraordinarily expensive as well. And now we've got, manufacturers putting in limits for the programs and so on, going even a step further. And so this is sort of a peak example, I think, of the complexity and the dysfunction. And so for me, the big takeaway, and I love the ideas about reforming benefit design, because it is foundational. It tells you, like, add-on solutions here, are probably not going to fix this. And in fact, as Jamie pointed out, that stuff all just gets repriced into the next generation of, product prices. And so we think we're saving money, and we're not even saving money, And but notions like benefit design changes and so on that are more foundational, that feels to me like those are the things that might have a chance to make things more rational and better for patients.
Great. Well, I can see why you were the A student and became the doctor, because you did a great job of sort of stepping back and taking a look at this from a larger perspective. And I think you bring up some fantastic points. And so again, let me just wrap up by saying thank you again to Lauren and Carl for joining us. You're a fantastic guest. I'll always thank my co-host, Dr. Scott Howell, for his joining me on this journey. Thrilled that we now have 7 episodes. I feel like we've been renewed, as I said. So we're excited about what we have ahead of us. And let me just say to all the listeners, thank you for listening to us. This was our first episode where it was driven by our listeners. So we encourage you to send emails to comments@prescriptionforbetteraccess.com and tune in to our new YouTube channel, which hasn't gotten a lot of coverage yet, but we've only been out for a couple of weeks. But we'd love for people, they could see us and see me losing my hair and getting stressed out. So, but thank you, everybody, and thank you for joining us today.
Yeah. Thanks, Mark. Thanks, Lauren and Carl.